Thanks to Mr. Suresh and the entire team of Catala and IAMICON for organizing on this mammoth scale such a stupendous program for the advancement of innovation, research and academia in this country. And again, so without wasting much time, I'll begin with my presentation on cardiovascular risk management. And basically my talk would focus on polypill, which is a subject which is very dear to me. I have been a part of the Empire trial, one of the only few trials published in this field, and it has been published in JAMA, and I was one of the investigators for this trial. And so I have some personal experiences also of treating people in a randomized controlled trial with polypill. So the talk would basically be divided into two sections. One would be the challenges of cardiovascular disease scenario in India, and then what are the best possible modalities for stratification and management of such patients that we can offer across the spectra of different socioeconomic status and levels of care. We are all very much aware as practicing physicians that the epidemiology of coronary heart disease is changing, and it is changing in a dramatic fashion in India. So much so that the older practitioners would recall that it was a disease of old people, mostly confined to people who were rich and mostly urbans. And now the scenario has changed absolutely. The disease has struck in each and every possible section of this society. And this pie chart just shows what we have always been seeing throughout our practicing years, that the proportion of people who are getting affected and who are dying because of different diseases is shrinking because of infectious diseases. It's not possibly as much shrinking from infectious diseases as increase in chronic disease burden, which is called the double whammy of disease burden. So while we have not really expunged the communicable diseases from our disease profile, we have accumulated a lot of chronic diseases into the disease spectrum in India. And the most prominent of these chronic diseases is cardiovascular disease, basically comprising of atherosclerotic vascular disease like CAD, as well as cerebrovascular disease and peripheral arterial disease. Again, this slide needs no explanation. We are all aware that cardiovascular disease is the #1 killer in India today. So who are getting affected? And this is something which really bears a moment of thought, because it's all those people who were not supposed to get this disease. They are the ones who are coming up in a big way with this disease. And you'll be surprised that we actually started a research project in Pant recently, and we were looking at young MIs, which is fairly common. I'm sure all of us have seen. But you'll be surprised that we did this project specifically for people under 30 years of age. And already in the last 6-7 months, we have more than 100 cases. This is just in one hospital. So you can imagine how much proportion of people are going to get affected, morbidity which is going to strike the productive years of these people. Again, we are seeing this in people who are driving rickshaws, people who are eating junk food on the street, people who have no access to healthcare or to insurance. So all the expenditure is out of pocket, which is a big thing because it's a resource intensive medicine. We are seeing this a lot in women who never were supposed to get, premenopausal women who were never supposed to get CAD theoretically, in urban migrants as well as in rural populations now, which are actually becoming more and more urbanized. So one of the key factors is that the risk factors have actually somehow, and this was actually brought about first of all realized, it was suspected, but first of all realized by the Inter-Heart study. The Inter-Heart study, I'm sure we are all aware, it was one of the biggest studies, case control studies of looking at the determinants of myocardial infarction across the world, and India was a part of it. A separate study then looked at the Southeast Asian population, of which the majority was from India, and that paper was also published in JAMA. And what they found was that while Indians were getting MI a decade earlier than the Western world, the causes remained the same. So the risk factors which were there in the Western world were actually there in the Indians also. But what was surprising was that we were getting these risk factors, we were accumulating these risk factors at a much earlier age. And that was the reason why we are getting MIs and other forms of atherosclerotic vascular disease at a much younger age. So we are all aware of these determinants, including urbanization, tobacco, reduced physical activity, changing dietary pattern, as well as improved life expectancy. And this is causing a dramatic increase in the number of cardiovascular diseases as well as earlier onset of this disease. Now, this is a thing which is well known for the almost last 50 years, is that the risk factors for cardiovascular disease travel together. And there is this clustering which has been given a formal name also called the metabolic syndrome now. Indians have an epidemic of metabolic syndrome, we are all aware of that. And this slide again is something which is not a shock to any of the audience here, because we have all seen people who have diabetes and they have hypertension, they are slightly obese, especially with abdominal obesity, and these are all people who are there in their 30s, which is what is disturbing, because this is not what is the usual profile seen in the developed nations. So I think one of the most important things which as physicians we need to address is routine screening of people. And by screening, it's not the kind of executive checkups which are which are quite prevalent. It is on a rational scientific basis of a periodicity, things which can cause, which are silent killers like diabetes, like high blood pressure, like cholesterol, and very important waist circumference, because Indians have a predilection for abdominal obesity while not having a very high BMI. And then obviously things like lifestyle assessment, physical activity and stress, these are all very important to be picked up right in the beginning, because they are the determinants on which the risk factor bed is formed. So we know that despite this, even if we pick up these people because of the behavioral tendencies for chronic therapies which are there, and these are universal across the world, they are not there just in India, across the world, people tend to become less and less compliant as the time duration of chronic therapy progresses. So it's a very famous saying that almost a quarter of people of hypertension are detected. Out of that, quarter are actually getting medicines, and a quarter of that are actually getting adequate control of their blood pressure. And this is a fact which is there to a large proportion in India, maybe a little lesser in US or in other countries, but it is there throughout the world. So I'll come to the basic focus of my talk now, which is on the polypoly, and this was just the rationale for why actually we are in desperate requirement of some kind of a magic bullet which can take care of our existing increased burden of disease. This is not for the people who are going to develop CVD or are in the future. It's for people who already have existing CVD or CVD equivalents, and this is where the polypol comes into the fore. So basically, Dr. Sir Geoffrey Rose in 1970s propounded the principles of cardiovascular risk assessment, and they are still true even today, and these are the principles on which the basic tenets on which the management of cardiovascular disease is done. And they are that cardiovascular risk factors aggregate together. So somebody who has hypertension has a higher likelihood of having diabetes, while somebody who has diabetes has a higher likelihood of having hypertension. Then a very important concept to understand, and that is that a single elevation, extreme elevation of one risk factor is less injurious for cardiovascular consequences as compared to mild elevation of multiple cardiovascular risk factors. And this is not hypothetical, this actually happens every day in our life. Somebody who's aged 35 has a BP of 180, 100, at least for atherosclerotic vascular disease has less risk as compared to a 55-year-old diabetic who smokes and has a blood pressure of about 150 systolic. Then the principle of multiplicative risk is very important. Moment these risks they start accumulating together, it just doesn't lead to an additive increase in the risk. The risk actually multiplies, so much so that if there are 9 of them together, which was shown in infrared and show you the slide later, the risk increases 29 times. And then the last one is that when we are treating these people for their risk factors, we have to look at the whole cardiovascular risk assessment in toto rather than treating a risk factor per se. And this concept is very, very important and crucial for good cardiovascular risk management. And that is, it has been borne now by several randomized controlled trials, notable like ASCOT, BPLA, where hypertensives actually, one of the big studies has shown that almost 80% of them actually will have one or more risk factors. So giving statins to hypertensives actually reduces the vascular risk as much as giving an antihypertensive itself. This may come as a surprise to many people, but this is the fact that the vascular disease is reduced as much by cholesterol lowering in these people as by lowering the blood pressure. So the cornerstones of atherosclerotic cardiovascular disease risk management are dependent on the level at which we are addressing. So primordial or primary prevention is more to do with the lifestyle changes, not to say that they are not practiced cornerstone, and those include the statins, antiplatelets, ACE inhibitors and beta blockers, and risk factor management and lifestyle therapy. The problem of modern medicine is not that we don't know all this. We know each and every word of what of this is. This is there, it's churned out every day in our books and our journals. The problem is that the problem lies in translation of these things into reality, because the evidence base is huge, it is there for a long time. The problem is in the delivery of this evidence base into the practice of people. And this is where there are barriers, because people just don't take medicines over a long run. This has been documented again and again in several different societies. And the problems are because of compliance to a medication which has to be taken day in, day out, maybe multiple times in a day for your life. It has to do with access to healthcare. So while in NCR we are lucky to have so many physicians, it is not so true for many other parts of India where there are remote healthcare facilities, and people because of either physical, geographical or socio-economic circumstances cannot have access to healthcare facilities. It has to do with complex treatment regimen, which means taking an oral hypoglycemic twice a day, a blood pressure lowering agent twice a day, plus an aspirin, plus something else. And with advancing age, people become confused, and it is a mess. And then obviously affordability, which is a big problem in countries like India. So the other thing which is important to understand is that not to say that lifestyle behavior modification is not important. I think it is the most important thing, but evidence base has shown that it is very difficult to change lifestyle. It is very difficult to change on a community or a nationwide scale, and when the change happens, it doesn't happen over years, it happens over decades. For example, like the way it happened in Finland or in Mauritius. So like in Mauritius, they had this huge problem of hypercholesterolemia and hypertension. They just decreased the national level of salt intake and changed the oil which was being used. Over a decade, it decreased in total cholesterol levels. So the thing is that these things take a lot of time. We don't have that much time. These things should be taken care of, but at the same time, we need to have new armaments in our new weapons in our armamentarium, so that people who are actually having the disease right now are also addressed. And this is where targeting secondary or high risk primary preventive subsets comes into being, because these people who already have had an event or who are going to have an event are at the highest risk. And this is where the polypill comes into the being, because polypill is a single thing which has probably going to be having the highest impact on this subset of people for averting future vascular events. The concept has been there for a century as a fixed dose combination for blood pressure lowering and for other drugs. However, in the field of cardiology, as a polypill word was coined the first time by M.R. Wald and Law in a seminal paper which was published in BMJ 2003. And their concept, which I'll just say because it's a very interesting thing. So Wald and Law had a very, very radical concept. It was a revolutionary concept. They thought that it is something which should be added like into the tap water. They had 6 drugs, 3 of them were blood pressure lowering agents, 1 statin, 1 aspirin, 1 folic acid. they propounded that give it to everyone above age of 50. You don't need to ask about presence or absence of CVD. You don't need to ask about their blood pressure status or diabetes or whatever. They just said that on a community level, if you give this polypill to everybody above the age of 50, you can prevent 80% of the future vascular events. This concept was very, very radical. It was probably rightly also criticized a lot by the scientific community as well as by the press. However, it had some merits, and this is what set the thinking in minds of several companies as well as scientists. And so because of this, several formulations came out over the next decade or so, and several trials also have happened into this place now. And I think this board here actually very nicely summarizes all the trials which have happened in this field till now and which are also going to be there in the future. So why polypill? That is the biggest question, because polypill is not something which is like black and white. It has shades of grey in it. It has its own problems, and which must be accepted and realized. My argument is that despite its weaknesses and limitations, I think it is still too much of a good product to really ignore. And the reason is because adherence to therapy actually improves drastically with polypill. It simplifies therapy. It simplifies therapy because, as I mentioned to you, that if you give it to a hypertensive, you are ensuring that his lipid is also lowered to some extent, because risk factors again travel together. It addresses a lot of healthcare access inequities. And again, this is very important for a person who's likely to see his doctor only once in a while, maybe once in a month or so. It is important that something is given which will take care in a comprehensive way for this patient. It actually improves outcomes, and this has been shown in some observational studies. And it is cheaper. It is cheaper in two different ways. Firstly, sometimes, and as it's happened here, that the combination actually is cheaper than the constituent drugs taken on their own. Also, because once you start taking this combination, then because of the aversion of the future events, the indirect costs of healthcare for the individual and for the nation also are decreased. So that way also it is significantly cheaper. And that is why almost all the large scientific bodies for cardiology worldwide have actually endorsed and are promoting this. Some of the top shots people in this world are actually conducting trials right now for this, and we are sure all of you must have heard the name of Salim Yusuf. Dr. Salim Yusuf is one of the biggest clinicians and trialists in the field of cardiology. He is from India. He's in Canada right now, and he has already done 2-3 studies on polypill, and he is conducting even further more studies on polypill. So the fact is that actually, the scientific societies have actually recommended the polypill for consumption, not just in places like India, because one thing has always been said that it is good for developing countries, while what about developed nations? Even for developed nations where cost is not a problem, but adherence still remains a problem, as I mentioned before. And this is why even in the developed nation it is being given. It's already being institutionalized, nationalized in a lot of South American countries, in Spain, and I think it's going to become even more institutionalized in further countries of Central Europe also. So just giving you a little bit of scientific background about the compliance part and how it impacts the scientific rationale, why compliance addressing is so important. So moment somebody has an MI, walks out of the hospital, within 1 month, almost 1/3 of the patients have discontinued their treatment. The treatment which is all life-saving, almost all the 4 treatments, that is aspirin, beta blockers, ACE inhibitors and ACE inhibitors and aspirin, they all reduce almost by 1/4 for all the vascular events. Despite this, within 1 month, people are actually discontinuing this treatment. This slide needs some food for thought. So this was the PURE study, one of the largest studies, observational study, done looking at compliance for cardiovascular medications in the community basis, not on a hospital basis, but on a community basis amongst people who already had vascular disease in terms of stroke or MI. And this trial was conducted pan-globally across all different kinds of nations. India was in this low income country group along with Pakistan, Bangladesh and Zimbabwe. Majority of the patients were obviously from India, so this is fairly representative of the condition in India. And you will be amazed that 75% people were actually taking no medicine when they were surveyed for this. So this is the reality which is there. 75% people are taking no medicine at all. And even people who are actually taking, as I told you, the compliance reduces as years go by. This is seen very radically here, that for some of the constituents for the polypill, like the statins, people just keep on dropping out of the picture as years go by. And this is the meta-analysis which shows that broadly about 50% people are taking medicines for risk reduction, either for primary prevention or secondary prevention. So at best, throughout the world, from studies from developed nations also, only 50% people take their medicines on a long term. What about physicians? As physicians, we obviously do better than the patients, but even physicians actually don't prescribe guideline-based therapies. Almost, even in Europe, about 30% physicians are not prescribing the guideline-based therapies. So the problem lies just not with the patient, but with us also. A lot of physicians do not prescribe things based on their fear or of thinking that this actually is not required. So for example, a physician might think that cholesterol is normal, so there is no need for a statin. Now, does it really matter when these people take or don't take? And this is where these two big studies were done in US and in Europe. So people who are actually compliant fare far better than people who are non-compliant with their medicines in terms of death as well as further events. This is the next study. So you can clearly see a dramatic change depending on how much of ACE inhibitor, statin or aspirin you're taking. If you're taking all the three, the deaths are much lower as compared to when you are actually taking none of them. And this is the slide I was talking to you about, the concept of multiplicative risk from Interheart. So MI risk increases by 26 times when there are 9 risk factors which are present together. And this thought is very sobering. So coming to this trial which was published last year in JAMA, which was conducted in India and in Europe. And this trial was the Empire trial, which was funded by European Union. And basically what they did was all the patients who had either had a vascular event or they had some kind of a atherosclerotic risk which was equivalent to that of an MI or a stroke were given either the usual care or the polypill. The polypill consisted of the usual elements of simvastatin, aspirin plus lisinopril as an ACE inhibitor, and then either atenolol or hydrochlorothiazide. So there were two options. And what was found was that about 10% increase in compliance took place within a span of 1 year. However, if you looked at people who were actually very less compliant to begin with, if you just concentrated on that subsection of population who had low compliance at the time of starting the trial, and then when the results were checked in these people, almost threefold increase in compliance was seen with the polypill as compared to individual constituents. And this actually translated into meaningful effects. The meaningful effects were about 3 mm systolic blood pressure reduction and about 5 milligrams reduction of LDL cholesterol. Again, for this subset, the effects were doubled. So about 5 to 6 mm of systolic blood pressure reduction in people who were less compliant to begin with. These are meaningful reductions, I think, over a longer period of time. And this is why, again, as I said before, polypill has actually become a reality, and the Bible of medicine, Harrison's, has got a separate chapter now which addresses this, and has been written by my mentor, Professor K.S. Reddy. So Polycap is actually the polypill which has been manufactured by Cadila, and it has been there for quite some time now. I think for about 3 to 4 years, 5 years, I think it has been there. And it's a very affordable drug, and it has been formally tested in the TIPS 1 and TIPS 2 trial also. So it has undergone several investigations and tests at the bench as well as the community level, and it has done fairly well. And I think the concept as well as as this pill actually deserves a lot of promotion in this regard. As I mentioned, that already published report about the bioavailability being, because that is something which people, the detractors for polypill have this notion that the bioavailability of drugs when they're given together might actually be affected. So again, this has been proven wrong, not just with this particular polypill, but with several other polypills. There are about 5 different kinds of polypills which are around there globally right now. The ones which are there actually, which are being distributed commercially, is one is this, as well as the other one is in Spain and in South America. And then the Indian polycap study, which was published in 2009, which was the proof of concept study in which these medicines were given to a specific cohort, and they found that there was significant reductions in both cholesterol as well as in blood pressure. And the better part, that much we do expect. After all, if we give blood pressure lowering drug and a statin, they are bound to decrease. But what was the bigger issue which was at test was the safety and tolerability of the drugs, and that was remarkably well tolerated. Even in the Empire study, the study was the drugs were remarkably well tolerated. So in my center we had about 40 patients, and despite having 10 mg of lisinopril and 50 mg of atenolol, I think only one patient out of 40 we had to discontinue the drug in reality. The rest all actually tolerated and continued taking the drug till the end. And then again, these are all just showing the meaningful changes which happen. So there is a concept of double dose of this, which was tested in TIPS too. So even people were given double the dose of this of the polycap, so which means 100 mg of atenolol and 10 mg of ramipril. Still, the tolerance was quite good. So just to wrap it up now, the advantages of polypill in my consideration are that it is cheap. It is cheap directly to buy. It is cheap because in the long run it saves you a vascular event. There can be no price put on somebody to have an MI or death, but if you were to put a price, that price will be very large. So in that terms, even for cost effectiveness purposes, for a policy maker or for a nation or for even an individual, it is a very, very good bargain. It reduces the treatment complexity. So instead of taking 3-4 different drugs at different times of the day, which you might be tending to forget, it just puts you, you can easily take it at any point of the time of the day, once a day. It increases adherence dramatically. It reduces therapeutic inertia of the physicians. And this is a very important thing, because a lot of times we might think twice before adding one more drug or taking out one drug, but giving this as one go, it makes it easier even for the physician. And if the resources are scant, which is what is happening in India, then it works even better. Who benefits from this? So practically speaking, it's people with vascular disease and people who are who have high risk for vascular disease. They are the ones who benefit a lot. My opinion is that some form of polypill will also be very beneficial for the younger people who actually have the most problems with adherence to chronic therapies. What are the possible harms? Because it's not just all rosy. There are possible harms also which can come through this. And one of my patients, he kept on having recurrent hypotension, and ultimately we had to take it off. The thing is that the detractors of polypill say that because of these things, you are taking 5 drugs. It's okay, you stop one drug, it's fine. If it's a polypill, you stop that, all the 5 drugs are stopped. That is the biggest criticism for polypill. However, in real life, in Empire study, when they investigated this, they found that in reality what happens is, if somebody stops polypill, he actually goes back and starts taking those 3 or 4 drugs individually once again at a lower dose. So, I mean, this is something which is a possible limitation of polypill, but in real life, this limitation does not hold true. So, as I said, for the high-risk primary prevention, there is not much evidence as of now, but this evidence is being generated right now, as of now when we speak. It hampers guideline goals, meeting the guideline goals. So, the blood pressure might not become reduced to the extent which you want by a polypill, but then you can obviously add another drug also to it. So I think that is not a limitation. The third point I've already addressed. The point which I find which is peculiar to India to some extent is seasonal changes in BP. Because in my practice I find that a lot of patients, the requirement for antihypertensives changes by the season, by winters and by summers, and this is where polypill might have a problem. And I think future ones probably there will be different forms of polypills available, so that you can tailor-made the adjustments for that. The stability and pharmacokinetics are not really a limitation. It has been adequately tested now. And the other fact is that all these polypills are using off-patent drugs. So we have simvastatin, we have atenolol. The problems with the newer ones are also there, because like metoprolol is shorter half-life. It is prone to several different polymorphisms, so metabolism is separate. So a lot of people say that like atenolol is not a good drug. It has been bashed a lot already by the scientific community. But I think when it has been given in the long run to these people, actually, so what proponents of polypill will say, and I agree with that, is it is more important to decrease the blood pressure rather than thinking of how it is to be decreased, because this decrease will matter much more than how or by what agent this was decreased. So just to summarize, I think cardiovascular disease is a big scourge for India. We need to really comprehensively start assessment of risk and management of risk at a very, very early level for Indians. And I think basically polypill is the way to go, at least for secondary prevention and high risk primary prevention. Thank you.